Hello, welcome and kumusta? Thank you for joining me. My name is How. I am your occupational therapist, and this is Occupational Therapy Conversations. In this episode, I'd like us to talk about clinical reasoning. I want us to have some further discussions about that, and I'd like to share with you some of the processes that I have. Whenever I'm doing practice, and every time we have collaborations or we want to explore things that work, there is always this topic that comes out, and it is about reflection of practice. And there are different models out there that's very popular. People are encouraging systems and processes. Personally, this thing is not normal for me. Reflection, in a sense that I would like to think about something after it has happened, because reflection in general, this involves thinking about what took place and the risk that has taken place. Now, reflection, it implies that actions already happened. So while it's a good thing that you can learn from the event, but it meant that there had been some situations or things could have happened that could have been catastrophic for me. That is always a near miss event. So retrospective reflecting is good, but for me, this is a reactive method of learning. And the method that I am sharing with you is a proactive method of learning. And this will facilitate a clinician to learn ahead and to be prepared for the clinical caseload that will fall on the clinician. So, what am I saying? This is what I'm saying. I'm happy and I respect that people are doing reflections, that people are learning from things that have taken place. That is good. My beef with it is that the learning only happens after an event has taken place and you could prevent these things. So rather than reflective learning, I would like to think more and I would recommend more of a proactive learning or anticipatory clinical reasoning. And we'll be talking about these things. We'll explore on different areas. So there will be some guiding questions. So the first one is we'll talk about the clinical reasoning guiding question. So some of the guiding question that runs in my head, and hopefully you can learn from this as well. So the first guiding question every time I come across a case or a scenario is, what is the problem? Somebody comes to me for advice and help, and they seek occupational therapist's advice. My first question is, what is the problem? Or if I go and see a person, when I do my assessment and evaluation, the first question that I want to find out is, what is the problem? You can't worry about some things when you don't know what the problems are. So know the problems. This is the one that will open up doors. This is the key. Whether you'd want to go on deeper into the case or whether there's a need for you to come in and be a part of that clinical case, what is the problem? So if you are meeting a person, for example, and you have a person in front of you and you're going to make these assessments. So the first question is, who is this person? Who's this patient that I am talking to? What does he do or what does she do? What are the occupational concerns? So as occupational therapist, I'm not going to be worrying so much about the medical condition at an instant. That's fine. They come into the hospital because there's a medical reason. I respect that. But that's a problem that is not pertinent. That's not overly pertinent to me. That may be a medical concern. Yes, I appreciate that that is a problem. But my problem, when I say about problem, is what are the problems pertinent to occupational therapist? So who is this person? What does he do? What are the occupational concerns? And when I say occupational concerns, These are occupational concerns regarding their ADLs. Are there things that you can't do? Is that a problem? So, performance area. Did they come to me because there's a problem at work? Is there an occupational concern, particularly in our domain, performance component? Is there a problem with the hand? Is there a problem with sensation? Is there numbness in the hand? Or are there some symptoms because of stroke, for example? Performance component. These are some of the concerns pertinent to me. I would look at concerns about their affect and emotion. If you go by with Canadian model of occupational performance, affective state or emotional state is a concern of occupational therapy. And this is one of the major components. You have the physical component, you have cognitive component, you have the affective component. Yes, if there are problems, then I would come in. Are there preoccupations? Are there patient preoccupations that worries them? So this will be a part of the affective concerns. And yes, I can go in and I will pay attention to that. Would I note some cognitive concerns? Are these concerns developing or getting worse, or because of the cognitive concerns, there are other problems that are happening at home? Like, are they getting forgetful? So I am zeroing in on the problems that is pertinent to occupational therapy. So that's the first step. Another concern that we're always missing are the contextual problems. Are there concerns because of the current situation? Is there family concern? Are there social concerns? Are there family concerns? I need to pay attention to these things because performance context is a domain of occupational therapy. So I would pay attention to that. I'd look at those concerns. Now, is the person acutely ill and they are recovering? So yes, there are concerns. And this is already the performance context of the disease condition or the state of their medical condition. And you know that with this, it can domino. The problems can trickle down on future recovery, or it can stunt recovery if they persist long in a particular state. So occupational therapists will definitely be required. That's why it's justifiable for us to be in critical care. So that's one. What is the problem? What are the concerns? So as an occupational therapist, do I need to know these problems? Sometimes you go and do a handover, people would say to you, oh, she's up for an x-ray today, or they're still on antibiotics. Yes, good. I understand that. That will be factored in. But that may not yet trigger the alarm bells that's going on in my head. Yeah. So as occupational therapist, I have a filter. And as occupational therapist and students, you need to have filters. Are these problems, concerns pertinent to you or to me as an occupational therapist? Now, just remember this, that you can help better if you know who the person is. You are advocates of occupation and what's happening in the current scenario. The current situation is a name will be given to a therapist. And what would this therapist do straight away? Look at the notes straight away. Look at the history. Yes, it's helpful that way. But the challenge in this process is that it already pre-paints, or it gives you what's the word? It gives the therapist a presumption of who the person is. Well, the fact of the matter is, what is important is for you to seriously know who your patients are as a person, as an occupational being, not as a person with little parts of medical history, not that. So it will really help if you know who the person is, because you will be basing your decision, you will be basing your advice, and the treatment will be based on the uniqueness of, so you will have to factor in the person. The other thing is you cannot make an informed decision if you do not know the person. That's the start. Yeah. So that's one. Know the problem, answer who is the person, what does he or she do, what are the occupational concerns. The next thing about understanding or having clinical reasoning, some of the guiding questions is, do you know enough about the case? And what are the things that you do not know? So if you do not know enough about the case, then it is your job to know about them. The case being, what's the situation? What is the medical condition? What are these conditions that the person is suffering from? You need to know the condition, in which case, not just knowing, you need to understand what they are. So this is a medical foundation. This is an occupational foundation. These are foundational skills for occupational therapists. Yeah. So if you don't know what diabetes is, what it entails, then know about it. Over a period of time, you'll have a buildup of this experience, then you'll learn about all of these conditions. It's your job and it's your professional responsibility to know about them. If you come across with motor neuron disease, what is it about? It's your job to know about it. If you come across with somebody who's had a stroke, then be sure that you know what stroke is. What is the nature of stroke? What are the functional implications? It's your job to know. It is your responsibility to know these things. As a professional, you are holding your own PIN or your own registration. You are your own therapist. It just happens that you are employed by the NHS, but you are professionally responsible for your own practice. So you have a responsibility to know and you have a duty to know. Another reason why you have a responsibility to know is because you will not be able to make clear decision making if you do not know the nature of that condition. And you have an ethical and you have a professional commitment to make informed decision. So know the person, the first stage. Next thing is, what's the problem? The medical condition. What are the functional problems? What is it that are causing those problems? What is it that's causing those problems? And if it is a condition, please know about them. You owe it to yourself that you should be equipped with these things. So you need to find out what is wrong and what is the problem. And after knowing these problems, I go over and over about, I'm yapping around problems. Does the person see it as a problem? Yeah, a problem only becomes a problem when it is acknowledged to be a problem and when it is seen to be a problem, or when you don't know that it is a problem and then you need to know that it is a problem. So does the person see it as a problem? So understand those problems. Like I said earlier on, is it a problem of performance area? Is it a problem of performance component? Or is it a problem of performance context? So as an occupational therapist, we are bound by the limits of our professional boundaries. Professional boundaries being you deal with the things that you are concerned about. And mind you, as occupational therapists, there is a lot of things that we are involved about, particularly when it comes to occupation, risk of occupational deprivation, inability to perform the things that they like to do, tasks, occupational tasks. There is a lot that we can be involved with, and we cannot say that there is no need for OT overall if we don't dig enough and the patient doesn't see those things enough. We need to understand it. So you cannot say that really there's no problem. You don't want to push, but you need to understand that you will not be short of things to do, because tasks are anything, any activities in the known universe that has significance to a person. So as an occupational therapist, we should be bound by the limits of our professional boundaries. So we have to work within the scope of the domain of the profession. Just remember, anything that we will do that is beyond the scope of the practice is technically illegal, and we're not supposed to cross the boundaries of our field as a professional courtesy to others. Now, this statement, I really feel a little bit sad because other professions are like that against us. There are other professions that are just crossing their boundaries, and because we're not there, we are not there standing our ground. I have encountered a physiotherapist one time, came to me, bless her. She was looking for a puzzle for her patient. And I thought that was very nice of you to do that. But why are you you're a physical therapist? And she said, because she is lonely and there's nothing for her to do. And I don't want her to feel isolated. And this is a physiotherapist who's saying this. And it breaks my heart because we should be doing it as an occupational therapist. We have occupational therapists working with this physiotherapist, and yet the physiotherapist has taken it upon herself to do the things that occupational therapists should be doing. Why was that? Because the occupational therapists were quick to decline referrals. So other people are doing it. And in this country, there's no such thing as professional boundaries. It's almost transdisciplinary. And people would mask it on the reason of caring. So another scenario where other professionals crossing professional boundaries is I have been approached by a physiotherapist one time, and she was writing a protocol for an access visit, thinking that it was her responsibility to do that as a physical therapist. When in the country, access visit has always been the domain of occupational therapists. So why was it that the physiotherapist felt that she'd be justified to do this? Maybe because she thinks the OTs were not doing it. But in fact, initiatives have been started by occupational therapists. So you see, people are crossing boundaries all the time. While I have the commitment to say, don't do that, don't cross boundaries, don't do the things that other professionals are doing, there's no check on this. And sometimes we may have to do this. We may have to play the game. Look at these, all of these efforts of ANP or advanced practitioners. Everybody's being trained to be advanced practitioners. Physiotherapists, occupational therapists, nurses doing advanced practitioners. To do what? To do diagnosing. So really, it's not the job, but people are almost encouraged to cross boundaries. Diagnosing has always been the job of a doctor, but because there are no doctors around and people can be paid for at a cheaper situation or at a cheaper rate, then here you go. Here are the ANPs. Yes, it meets the need. It meets the pragmatic need. Okay, we've gone political there. Okay, so those are some of the clinical guiding questions or clinical reason guiding questions. Now, on the attempts to resolve problems that are pertinent to occupational therapists, these are some of the questions that I have. Are the problems resolvable? That's the first question. Are you going to be delving on problems that you really cannot resolve? Is it a condition that is resolvable or not? How long will the problem be resolved? Is another question that I would do. And how long being, say, for example, washing and dressing, the person cannot dress. If I have to practice this ADL retraining and do some dressing training, how long will this problem be resolved? How long do you anticipate for this problem to be resolved? If it was a simple fracture, not going to be a problem. You can get a person independent very soon, particularly if they're young. If you have a stroke, depending on the severity, it can be a little bit longer. If you have a head injury, that can be so long, depending on the severity. If you have a spinal cord injury patient, that can take a very long time as well. So know that. How long will the problem be? How long will the problem be resolved? The next question is, what are my options to resolve the problem. So how do you want to restore or to resolve these problems? Will you be restoring the body? Will you be modifying ways? Or will you use adaptive aids? Will you need to support it? Or will you need to pass this on to others? The other things are, another question is, what are the conditions that are needed to resolve these problems? So what do I mean by that? Are the problems reliant on medical stability of the patient? Are the problems reliant on physical abilities? Are the problems reliant on the response from others, like family members or any significant people? And the last question on this is, can I resolve this by solving the physical problem or by adjusting and working around the problem? So these are attempts to resolve problems, yeah? And particularly when it comes to ADLs. So is it resolvable? How long do you need before you can resolve this problem? What are the options to resolve this problem? Are you going to restore the problem? Are you going to modify your ways around it? Are you going to support? Are you going to pass it on for other people to resolve because you don't have the time? Okay, and what are the conditions that are required? Is it reliant on medical stability? Is it reliant on physical disability? Is it reliant on others? All right. So that is my process when it comes to addressing and resolving problems. Another thing is on planning and delivering the treatment. So now you've planned it. So the first one is you've got guiding questions about the problems. What do you need to know? You need to understand it. The next thing, after understanding what that problem is, what are my options? And that would be to resolve the problems. And then the next thing is now you have to deliver the treatment. Okay, this is implementation of the treatment. So these are some of the guiding thoughts or questions that I have on this matter. So if I were to physically deliver the treatment, do I have enough skill to provide the treatment as an occupational therapist? So you thought, okay, I'm going to do ADL retraining for this person as an occupational therapist. Do I have enough skill to do this? If not, then I need to have it. So if you don't have the skill to deliver this treatment intervention, make sure that you know how to deliver this treatment intervention before you can pass it to another staff member or like the rehabilitation assistant. And again, this is more on the professionalism and the actual being professional. Not just professionalism, it's being professional. If you delegate an upper limb retraining to an assistant, are you sure that you know how to do it? Because it's going to get back to you. Sometimes clinicians are just passing things on to an assistant and they look very confident. But when it comes to the situation where you put the assistant and the clinician side by side, it seems like the assistant has more skills. The assistant have more skills than the clinician. And that's because clinicians have gotten away by just passing it on, delegating. You need to build that skill. So the things that you're going to pass on, make sure that you know how to do it. You need to walk the walk and talk the talk, or walk the talk, whatever it is that you call it. If there are treatments that needed to happen, the next questions are, who can deliver the treatment? Does it have to be an OT, or can it be done by a rehabilitation assistant? If it's a straightforward washing and dressing, as an occupational therapist, that should be straightforward. You need to have this basic skill of doing this. You can pass it on to an assistant. That's fine. If you need to do cognitive retraining, this is very tricky to pass it on to another assistant because it involves consistent and constant analysis of the responses. And even the responses, it's hard to document that. So you have to be mindful when you have to pass on high level of cognitive perceptual retraining to an assistant. So it's got to be an occupational therapist because you may need to understand the response of the person. So does it have to be an OT or can it be done by a rehab assistant? The next question would be, am I going to oversee this? Is it going to be my call? Yeah. Every time you pass something on to somebody on a daily basis, if you're overseeing the case on that particular day, that is your call. You need to oversee what's going to happen. You don't just pass it on to assistant and then just leave it. You need to oversee it. You can even pass things on to healthcare support workers. That's fine. For ADL retraining, you encourage them to be independent with toilet hygiene. That's fine. But you need to come back and oversee what's been happening. So that's going to be your call. Is the treatment happening as I planned it to be and as how I anticipate it to be? So think about that. You're doing your training, you're doing your sessions. Is it happening as you are planning it to be? And what do you need to do to ensure before I can say that the person can leave my care? So another question is, what do you need to do? What do you need to ensure before you can say that this person can leave your care? In the end, have you resolved the problem? Okay, these are some of the guiding questions on the treatment delivery. Okay, so a few more guiding questions. Again, to remind you, what is the problem? And with this problem, what do you want as an outcome? How do you want to address that problem? And in the end, the question that you need to answer is, have you resolved that problem? You have to compare it based on the outcome that you have anticipated on. So there you go, guys. I hope you learned a little something today, and we've talked about some of the methods on what you can think about before you do your treatment and treatment implementation. In that way, when it comes to thinking about your practice, it doesn't just become retrospective reflection. This is more of a preset guiding questions that you need to ask yourself so that when you deliver the treatment, you know that there is less chance for mistake. I hope you learned a little something today, guys. Until next time, bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. So if you have any questions or if you have topics that you want me to talk about, drop me an email. It's riot.conversations@gmail.com. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.